the years, and I can see lots of familiar faces. I know there have been teething problems related to what we have been doing. And as a result, because of the teething problems, I would just say welcome to each and every one of us. And I hope we will have excellent deliberations during this session. Thank you very much, Taurai and Jacob. Over to you.
We are from Morocco. I'm the president of the Moroccan Society of Epilepsy and also the coordinator of telemedicine. And I think our collaboration is really a very good point in this African Alliance, and I'm very helpful, very happy to be a member of the Alliance. We are ready to collaborate and to help and to make a lot of productions, papers and projects and sessions in telemedicine. So good luck in this webinar.
So thank you for the organizers for having me. Let me acknowledge the members of the pediatric arm of the Zimbabwe League Against Epilepsy, Dr. Mdawarima and Dr. Moyofiri, who are also in the audience. So the outline of my presentation, really, I'll just talk a bit about the background in pediatric epilepsy. I was hoping that I was going to come forth and that the other presenters would have given the background, but nonetheless, I'll just try my best. I'll talk a bit. My topic, as you've already seen, is talking about pediatric epilepsy priority at the primary health center. I'll also describe a bit about the treatment gap and the strategies to improve care. So, where is the burden of pediatric epilepsy? Approximately 50 million people around the whole world have epilepsy. And we know that 80% live in developing countries. Pediatric epilepsy in the developed countries is estimated at between 1 to 2%. The burden of childhood epilepsy is greatest in Africa compared to all the other continents. And this is attributed to a higher incidence of risk factors for epilepsy, particularly in the low to medium income countries. Sadly, these risk factors are largely preventable, and we're talking about perinatal insults, infections, traumatic brain injury. When we look at the burden of pediatric epilepsy, even in these resource-restricted countries, we note that the rural areas are particularly more affected, as these have limited resources to diagnosis and treatment. This image depicts the mortality due to epilepsy in the territories affected in proportions to the number who died of epilepsy per million population per year. As you can appreciate, Africa has exceptionally high death rates. And this sort of suggests that the risk of lack of treatment rather than the high prevalence attribute to the mortality. This map is being reproduced courtesy of MEPA.org. I think for adults as well as particularly so in pediatric epilepsy, sometimes the epilepsy per se is not the major burden for the family. They also have comorbidities. Comorbidities, this is a disorder coexisting with epilepsy, which may precede the epilepsy or may be directly attributed to the epilepsy or its treatment. 4 in 5 children with epilepsy have at least one comorbid disorder. And these include behavioral disorders, intellectual impairment, emotional trauma, developmental, and psychiatric disorders. These comorbidities, especially if not identified and managed appropriately, aggravate the burden associated with pediatric epilepsy. Identifying the main morbidities of epilepsy and their relative importance is crucial for improving the quality of care in children. And also we note that delay in starting epilepsy treatment is present in about 70% of cases, especially where there is an occurrence of comorbidities. Lack of data. There's lack of data. There's a few studies have been done in Africa. This is courtesy from this slide which I'm presenting is courtesy from a systematic review that was done by Eimu Wiga et al., where they're documenting comorbidities of epilepsy in low to medium income countries. As you can appreciate, the yellow represent countries with studies on comorbidities. And Africa, there is a high dense in some areas, but largely there are not many studies that have been done on comorbidities in epilepsy. Another study that I'm going to quote by Professor Joe Wilmhurst, ECTEL, documented the current status of pediatric management in Africa. And these were the disparities that they noted, that there's a challenge to accessing care, getting correct diagnosis was near to impossible. There's stigma, which impairs the management of pediatric epilepsy. There's unavailability of anti-epileptic drugs, partially due to the high cost. And then in those areas that are difficult to reach, particularly in war-torn areas or areas where there's been displacement of people due to extremes of weather, it also presented a challenge to the management of children. Just coming back to my local setting, Zimbabwe. Zimbabwe has a population of 18 million, and 68% of the Zimbabwean population is rural-based. The health system follows a four-tier system: primary, district, provincial, and then tertiary. Health personnel, in a study which documented the status of challenges in the care of children, most of the children, before they were seen by a doctor, were managed by a nurse in a primary care center or a nurse in a municipality center. Insofar as the people who are looking after children in Zimbabwe, primary care doctors, psychiatrists, 3 adult neurologists, they also go to faith healers and also are managed by traditional healers. In a study done by Dr. in partial fulfillment of a dissertation by Dr. Muyofiri among children admitted with acute seizures at 2 tertiary hospitals, they described some of the drugs that children who were coming with prolonged seizures were receiving. Diazepam was the drug of choice for status epilepticus, and some were receiving phenobarbital. Second-line drugs were generally not available, partially due to cost. So, what treatment gaps have been identified? If we look at the global arena, it is estimated that in epilepsy treatment, approximately 75% treatment gap exists. It is estimated that if treatment coverage with proper anti-epileptic drugs was expanded to cover that 50% gap of the cases, the current global burden of epilepsy would actually be reduced to between 15 and 40%. Children are not accessing care. Why? Due to lack of physicians, due to unavailability of drugs, or if the drugs are there, they're usually adult formulations. There is also lack of information at individual level, at communal level, and just education on epilepsy, both for people with epilepsy and their family members. And also peculiar to Africa, there's incomplete data. There are few national epilepsy registries that are active and are collecting synchronized data. So what can be done? Children with epilepsy should really be identified at a primary health care center. Why? Because this is where the vast majority present. The Declaration of Amata defines primary health care as an essential health care based on practical, scientifically sound, socially acceptable methods and technically made universally accessible to individuals and families in the communities through their full participation and at a cost that the community and the country can afford. As simple as it sounds, it is actually a challenge as evidenced by the treatment gap that still exists. 70% of pediatric cases can actually be controlled and their seizures prevented with simple, cost-effective interventions implemented at the primary health center. What can we do? We can strengthen the response capacity in the primary health center through the following activities. 1, meet the training needs of the professionals and the technical personnel working in the primary health center. 2, ensure that specialists at the secondary referral level can provide support and systematic supervision. Provide protocols and clinical guidelines for primary health care physicians. This sounds easy if you are coming from the Northern Hemisphere, but it is a challenge for most of the sub-Saharan countries. Establish regular mechanism for interconsultation and for referral and counter-referral. This helps particularly in the mentorship. Decentralize specialized neurological care in health service network, bring it closer to the first level. Avail and deliver anti-epileptic drugs. Of course, establish registers. I'm sorry if this is not projecting, but at country level, these are some of the key measures that can be done to improve children with epilepsy. There must be financing, there must be appropriate legislation, there must be a sound, robust health promotion, and epilepsy prevention measures. Delivery of health services, this should be aimed at integrating epilepsy management into the primary health center. Human resources should be strengthened, particularly to train health workers in order to improve their competence in epilepsy management, with special emphasis in the primary health care workers. Increase access to medicine, strengthen health information and surveillance system, and collaborate with civil society and partners. These were some of the indicators that could be used to assist in making sure that the epilepsy agenda is kept on track, especially for just looking at the primary health care system. Ensure that the laws exist. This can be done. Improve data collection, document number of epilepsy cases, and not just collecting the number of epilepsy cases, but disaggregate them by age and sex. Document the ratio of epilepsy consultation per 100,000 population. Remember, where data does not exist, it is difficult for planners to be able to put in robust interventions to address the problem. So in summary, the care of children with epilepsy in low to medium income countries still remains suboptimal. Main areas to be addressed include improving access of children with epilepsy to health facilities, particularly for diagnosis and treatment to reduce the burden of epilepsy. Strengthen epilepsy management in primary health care, and strengthen national research in the field of epilepsy. We should aim to leave no one behind. Please allow me to acknowledge Zimbabwe Charter of International League Against Epilepsy, children with epilepsy and their families who allowed us to share some of their data. Thank you, Mashita, and thank you for listening.
Thank you. Thank you very much, Dr. Kandawasvika.